chronic illness, which are on the rise. Now, chronically ill patients have higher frequency of visits to the emergency room, higher readmissions to the hospital, and the expenditures that are expected, and even those that we have currently, are very high. In fact, compliance is one of the biggest challenges of health systems today. And in all the studies on compliance, we have the element of communication, which is highlighted and is perceived to be very important in compliance to recommendations, to medications and guidelines. And it was also very important during COVID regarding the compliance with policies and guidelines. Now, communication studies present and claim that culturally adapted communication will promote compliance. We wanted to test this leading paradigm and ask, is it the same as far as physical distancing goes as we were introduced to it during COVID-19? And this is the focus of this study. We know that physical distancing was proven to be very effective in containing the virus. Governments across the globe implemented various practices of physical distancing. And even when the vaccines were introduced, their uptake was limited, and physical distancing remained the main intervention to contain the virus. Health authorities across the globe invested so many efforts in bringing people to comply with physical distancing guidelines, but still in minority populations, especially religious minorities, the rate of compliance was very low. And we wanted to test what we know about compliance in the context of the COVID-19. So we were presented with evidence in many of the countries where we did the studies that showed that compliance of minorities was poor, and it became obvious that people will comply better if the messages will be culturally crafted. Policymakers were using this knowledge in their communication messages, inserting cultural characteristics and needs of minority populations into the designing of messages. But still, there was a failure to contain the virus, and that affected the major population too, resulting in very high morbidity in different population groups, not only religious minorities. In Israel, when we look about the composition of the population, 12.6% of the populations are ultra-Orthodox Jewish people, but 40% of them were the hospitalized patients for COVID. And as far as the Muslim population goes, 21% of the population is Muslim, including Bedouins, Druze, but 33% of hospitalized patients during COVID, because of COVID, were Muslim patients. So the efforts of the media campaign were culturally adapted messages, and still that didn't make a big difference. Now, what is common to all the 6 religious minorities in Israel? First of all, behaviors of members of minority populations were determined mostly by the religious and spiritual leaders. Poor compliance was attributed to cultural attributes, for example, large families living in more crowded, dense areas, collectivism. So I will behave the way that my community is behaving. And Leaders of these religious minorities were asked to encourage compliance with physical distancing, but that didn't work as well. The social representation theory believes that since risk perception has cultural roots, then if we adapt culturally crafted communication, it will enhance voluntary compliance with physical distancing. And also the social representation theory believes that messages that reflect the shared reality of the community will yield higher willingness to comply with social distancing. So what we wanted to do is test which messages are drivers of compliance in each one of the religious subgroups in the population. We identified messages that drive willingness to comply based on a thorough literature search, and we wanted to understand which messages make a difference, which messages promote willingness to comply, which messages have no effect, and which messages adversely impact the willingness to comply. Our research questions are presented here. How do people respond to messages by the different components of the message? And do patterns of response to messages differ by the religious groupings? What do you think that we found? Anyone? Okay, I'll keep going. We had three hypotheses of the study regarding the extent to which people will respond to messages depending on how they identify with the message. We knew that the messaging may carry a different appeal to unspecified groups of people. And also the third hypothesis was that the similarity in responses to a set of messages will lead to the emergence of differently profounded groups. We composed experimental designs. The dependent variable was the willingness to comply with physical distancing, and the experimental designs were based on conjoint analysis. We had 4 categories of messages. Each category represented a different driver of willingness to comply based on the literature search. Each participant ranked 24 combinations of different communication messages with a total of 21,500 messages. The rating question that participants responded to was, to what extent does the following combination of communication messages drive your willingness to comply? And the rating scale ranged from 1, which doesn't at all affect my willingness, to 9, which strongly affects my willingness. As I said before, there were 4 categories of messages, independent variables, with 4 messages in each one. And this is how the screen looked. This was an online study for most of the members of communities, with some communities that weren't very strong on Wi-Fi connections. Research assistants arrived in those communities and met with people to fill out the online questionnaire using tablets and iPads. In the data analysis, in order to ensure statistical independence of the independent variables, the experimental design mathematically dictated the order and the combination of the messages, and the reliabilities of the instrument were tested with split halves, and the reliability was around 0.76. Of course, people signed an informed consent for participation and publication. And we had 896 respondents from the 6 cultural groups in Israel. So we had secular Jews, we had Muslims, which were about the same size, we had Druze, Christian Arabs, and Orthodox Jews and Bedouins. These were the 6 groups. The ages ranged from 13 to about 70. And what did we see in the hypothesis testing in terms of the results? We had individual level regression models and group level regression models. Now, based on the social representation theory, we expected to find that members of each religious culture will be driven by different messages to compliance with physical distancing. But the T and P values in the regression models indicated absolutely no significant difference. And also when we tested responses by gender, age, or self-defined religious cultural group, there were also no significant differences. This is how it looked. So the numbers represent the coefficients or the betas, if you want, and those were not significant, which meant that we need to test if when we walk away from the total panel and do a mathematical k-means clustering, do we get different results? And what we got was that 3 segments emerged. Each segment was significantly different than the others, and there were different messages driving the compliance in each one of those segments. So the patterns differed among these significantly distinct segments, and this is now how it looked. So we had significant betas, and people responded by patterns regardless of their cultural religious groups. The first mindset comprised of members that were pandemic observers, focusing on the risk of the virus and paying attention to the news. The second mindset was comprised of people who we called obedient followers. They focused on the practices of social distancing, and they expected to be told exactly what to do. The third mindset was comprised of sensitive interpreters, which were following what the government decided to do. The size of the segments was very similar. And what did we learn by that? And how do we translate this knowledge not only to policy implications, but also to compliance with medications? We can use the same strategy of understanding what segments underlie the data. What we did in this case, once the segments emerged, we developed, based on a Monte Carlo simulation, we developed a predictive algorithm. This algorithm is a tool we can use to assign people in the population to a segment in the study. So this is how the predictive algorithm is created. We created using messages that distinguish among segments. People fill out the predictive algorithm, and that way we know how to communicate with people depending on their segment belonging. So what we found is that the social representation theory, which is a very strong theory, did not play well and did not structure compliance in COVID. what we saw is a new phenomena that the findings illustrated. And this phenomena is called cognitive polyphasia. It means that members of distinct religious cultures obtain different information, are exposed to different experiences, not only as a group, but especially as individuals. And it means that the different sources of information generate a variety of ways that people process the information, and it doesn't go necessarily by the culture. What we saw again and again in Canada, the US, India, Hungary, Israel, is that in COVID-19, members of distinct religious cultures employ variegated social representations and do not abide just by what the religious leadership or spiritual leadership or what the members of their cultural religious group do. So the segments that we found transcend the religious cultural groups. What that means is that we have policy implications that we can apply here. We need to tailor messages not by the religious culture, but tailor them by the segment belonging, use a predictive algorithm that is based on mathematical clustering to detect the segment belonging. Once we have the predictive algorithm, we can direct people to a web-based page to fill in the predictive algorithm and assign people ahead of time to segments, communicate using these messages. And what we also saw is that people abide not only by the perceived risk, abide by how the messages were communicated. And surprisingly, people prefer that messages will be communicated through the media, not through politicians or religious leaders. The co-authors are Dr. Howard Moscovich and Dr. Attila Geer. And I can open up the stage for questions if you have any. So thank you very much.